These are my teachers. I was fortunate that being a orthopedic from a background, I was fortunate to be trained by a neurosurgeon, and I started my journey as an aggressive open surgeon, and I did them for 4 years. Uh, since 2012, I have embraced the art of spine endoscopy, and we had a lot of issues when we started because of limited instruments and limited technology, and we had to innovate to continue endoscopy. Otherwise, like many of my friends, I would have stopped endoscopy and said it is not good. And that time endoscopy was very expensive, and my goal was to make it very affordable. Whatever money I paid in 2012, today you can get a much better with set with the same money. Imagine 15 lakh rupees back in 2012. Today you can get much better system and more instruments with the same money. So my life changed after 2011. This was the first endoscopy I did in 2012. Transforaminal approach. Even till date he is absolutely fine. So this is the post-operative MRI just to confirm that you have done a good job. Coming to the percutaneous screws, of course we know that cannulated pedicle screws are the gold standard for percutaneous fixation. However, some drawbacks are also there. These are very expensive, especially if you are practicing in a peripheral center. They cost at least double the money. Even the cheapest Indian implant will cost you double the money. You need 4 incisions to put 4 screws. Sometimes you can have issues with guide wires like breakage, migration, and these cannulated screws, theoretically they are weaker, but practically it may not make much of a difference. So my technique is I use a transverse skin incision. I can put 2 screws in 1 incision, and I use standard reduction screws. No special instruments are required, and rod is inserted by freehand technique. I'll show a video how it is done. So we use normal C-arm, and initially we have to mark because we don't want any radiation on us. So I don't take any C-arm shots with my hand in the field. I am thankful to Ajay because he saw me operating in one of the live workshops. He warned me, don't get yourself radiated. So ever since I don't take any radiation on my body. So we make a 1 inch incision, transverse incision, not vertical, transverse incision, split the fascia. Then we put the normal instruments like you do open surgery. The initial entry with owl, the tap, then we feel the pedicle, but we don't put the screw in the same time. Then we go to the next level, lower level. So that is the tapping for the lower pedicle. That is the S1 pedicle. You can see the tap. If you want to put screw on the other cortex, that also can be put. Again you can feel both the pedicles, L5 and S1, and then we put the screw. Once you make the initial hole, it is very easy to find the hole. You have to have the mental picture where the hole is, and you can just go in and put the screw. So we put 1 screw, park that screw, it is under the fascia. Then you put the S1 screw. And you take all these steps, you monitor to C-arm. You can see one side the screws have been put. We go to the other side. So same way, we put the L5 first and then the S1. If it is 4-5, we put the 4 and then the L5 screw. So this is the S1 screw being put. So if it is a listhesis, then you, so this after 4 screws, and we put the rods freehand. Just use a artery forceps, fix it at S1. tighten it, break the fins. I operate with just one nurse. No assistance required. One small gelpi is enough for me for doing these cases. Then you reduce the listhesis with this nut and get the reduction. Then you fuse it with whatever way you want. You want to put a transcabin or interlaminar approach, and that is the skin incision. I'll show some cases which I did with this technique. This is a L4-5 light ecclesis, osteoporotic patient with left-sided sciatica. You can see that this space is collapsed with foraminal narrowing. This is how we put the screws, reduce it, and then put a transcambin cage. You can see the beauty of this transverse scar. It heals without any skin sutures. I just put couple of subcutaneous sutures and leave it. No skin sutures. And it heals very well. Once it heals, it gives an excellent cosmetic scar. And this is the X-ray post-op. And that is the follow-up X-ray. The patient is doing very well. There is another case, grade 2 to 3 light ecclesis with bilateral sciatica. It is a dysplastic ecclesis. And this was again with the transcambin fusion. That is a post-operative X-ray. We could achieve full reduction. This is another challenging case. L5S1 grade 2 listhesis, L4-5 grade 3 light ecclesis with the osteoporosis. This is a flexion extension X-rays. There is not much mobility. The MRI, the axial sections, we could achieve full reduction of this using reduction screws and transcambin fusion, and patient was fully relieved of her symptoms. We can do this even in fractures. This is a fracture dislocation with retropulse fragments. I normally don't fuse these fractures. I do just percutaneous fixation. Full reduction was achieved with percutaneous technique, and that is the follow-up X-ray. At 1 year, we will remove these implants, and patient is having all mobile segments. However, there are drawbacks. There is some longer operating time. If the patient is very obese, it is difficult, and sometimes rod insertion can be tricky and will take some time. I've done a lot of innovation in endoscopic surgery. I will just give only 2 small examples because it will take a lot of time. When you had these hooks and curettes, they used to open up, because when we use source, it used to open at the joint. So this is a very small modification I did. You can see here, we just asked the implant manufacturer to add extra piece of metal here. After that, there is no breakage. So don't blame the manufacturer. You try to find a solution. So once we did this, there is no breakage. Today, almost all the companies have copied this technique. Another case, when we do interlaminar surgery, we need lot of soft tissue clearance for endoscopy. I've been advocating monopolar cautery for a long time. Nobody believed me. Only answer I got was, it will not work underwater. But today, more than 100 of our endoscopic surgeons are extremely happy with this monopolar cautery. There is no tool available in the market which is as effective as this. No tool. So this has made our job and life very easy. So innovation distinguishes between a leader and a follower. And learning and innovation go in hand. The arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. That's why we keep innovating. Take home message, keep innovating so that your life becomes easy. Thank you.